My life changed completely in 2003 when I was diagnosed with idiopathic dilated cardiomyopathy. That's when I met Dr. Gregg Fonarow. He is the interim chief of cardiology here at UCLA and the director of the Ahmanson-UCLA Cardiomyopathy Center. He is one of the physicians who saved my life. I hope you enjoy my conversation with Dr. Gregg Fonarow. What advice or tips can you give a patient that has been recently diagnosed with heart failure?
So, this is so important because the wording matters. If you look up on the internet through natural history and what that prior prognosis has been, it's appropriate to be concerned because it can be a truly life-altering and life-threatening condition. So the key is taking it really seriously, understanding and making sure that the right diagnosis has been made, what underlying conditions and comorbidity can be contributing, getting to the right center and right clinicians so that you can receive that kind of proper care, asking the questions, okay, what is the treatment plan? What additional tests are going to be necessary? And what we know is so critically important is getting on those right therapies, finding the right dose, getting them started, really quickly, and then closely monitoring progress. And if we do that, it can really make a meaningful impact. So it's appropriate to be scared, but also optimistic that with the right therapies, care, and management, really important improvements can be made, and in some cases can normalize heart function and, go back to unlimited life potential.
How has the medicine around heart failure evolved and changed over the past 20 years since I was initially diagnosed and became a heart failure patient?
There really have been a phenomenal set of discoveries made, tested in randomized clinical trials, and clinically available and demonstrated to provide benefit. 20 years ago, we really just had a few medications that could stabilize heart conditions. We had relatively few procedures or devices that could provide meaningful benefits, but so much has evolved since then. We have a number of medications that have been shown to help make patients feel better, control their symptoms, in some cases reverse the underlying disease process in a way that can extend survival, and each of these therapies being additive. They're devices that also can help make individuals with heart dysfunction feel better and live longer. And for certain conditions, specialized procedures that can also improve clinical outcome. So we've never been able to do as much as we can for individuals with heart failure, make precise diagnoses, come up with a treatment plan that is going to meaningfully impact their quality of life and longevity. So while there are challenges that remain, really phenomenal progress has been made.
What is cardiomyopathy?
So in the simplest term is some form of heart muscle disease. So it encompasses a whole set of different diseases that can ultimately result in heart muscle dysfunction. The clinical syndrome that can present when the heart muscle isn't functioning well gets this term heart failure, which really is indicating the heart function isn't normal. So that can manifest itself as shortness of breath or arrhythmias, exercise intolerance. The heart muscle dysfunction will manifest itself where the heart doesn't either relax as well or doesn't squeeze as well. And we can use a non-invasive test called echocardiography, ultrasound of the heart, to really visualize that, as well as see how the valves are functioning, each of the walls of the heart, and other parameters that we get through that. In some cases, there are specific diseases that are damaging the heart muscle itself. In some cases, it's genetic. In some cases, there are environmental toxins that are playing a role. So there are a whole host of conditions that can contribute to cardiomyopathy. And what we have to do is, treat the underlying diseases, as well as, no matter what has caused the heart muscle damage, trying to restore the function of the heart.
And what are the different types of cardiomyopathy?
So the major and most common types in the United States, so-called ischemic cardiomyopathy, where the damage is actually done through heart attacks that have occurred due to coronary artery disease. There's also non-ischemic cardiomyopathy, and that often can be related to high blood pressure, hypertension. There are familial forms of cardiomyopathy that are a type of non-ischemic cardiomyopathy, and that's where there's one or more genetic differences or variants that affect the expression of those proteins in the heart and ultimately cause cardiomyopathy. And then there are a whole host of specific conditions that can cause inflammation of the heart or infiltration of the heart. So there are a whole variety of non-ischemic cardiomyopathies. And then there's heart failure that's related where the heart really doesn't relax as well. And we talk about heart failure with preserved ejection fraction. That can be related to non-ischemic forms of cardiomyopathy, as well as even ischemic cardiomyopathy can contribute to that.
The most common types of cardiomyopathy that I've heard about is what I have, which is idiopathic or dilated cardiomyopathy or hypertrophic cardiomyopathy. Can you tell us about the difference between dilated cardiomyopathy and hypertrophic cardiomyopathy?
Yeah, so those two cardiomyopathies, one is hypertrophic cardiomyopathy where the heart muscle thickens, and that thickening can impair the ability of the heart to eject blood or even lead to some obstruction of the outflow tract. So ejection of the blood from the heart can be a problem, and those individuals can be prone to arrhythmias and premature sudden cardiac death. Dilated cardiomyopathy is what it sounds like. The heart actually dilates. So rather than getting thicker, the size of the heart expands. Heart isn't squeezing as well with that condition. That can be due to different types of genetic abnormalities. It can be due to form of alcohol can affect the heart, of viral infections can affect the heart and cause a dilated cardiomyopathy. And sometimes, despite our best efforts, we can't figure out the cause of the underlying cardiomyopathy, and we use this term of, idiopathic. That means we haven't yet figured out that underlying cause.
Although my diagnosis has been updated recently to arrhythmogenic cardiomyopathy. So what is arrhythmogenic cardiomyopathy?
Yeah, so in certain cases, there can be an abnormal focus causing arrhythmias in the heart where extra beats are occurring so frequently, it actually disrupts the kind of normal function of the heart, changes some of the gene expression in a way where a cardiomyopathy occurs. And there, why we treat it with some of the same medications we use no matter what the underlying cause is, if you can treat that arrhythmic focus and eliminate it, the heart can gradually recover and even back to normal function. So that's where a specific form of cardiac ablation therapy can truly be disease modifying. We also have learned that, a common arrhythmia, atrial fibrillation, in certain circumstances, because it makes the heart beat irregularly and faster than normal, can cause a form of cardiomyopathy. And if you treat that atrial fibrillation, most commonly with a form of ablation therapy or cardioversion, then restore normal sinus rhythm, the heart can also improve or in some cases recover.
I remember when I was first diagnosed with idiopathic dilated cardiomyopathy, I was given the prognosis of 1/3 of the patients get better, 1/3 stay the same, and 1/3 decline. What is the prognosis now for cardiomyopathy patients or heart failure patients?
So it's actually improved with these medications. It's now closer to 50 or 60% of individuals we can make that meaningful improvement in ventricular function, and as many as 20-25% normalize heart function, right, which is remarkable from where we were. Fortunately, there are still some individuals that may progress. Device therapies can sometimes help, and there are still a component of patients where more advanced therapies, things like left ventricular assist devices or heart transplantation, are necessary, but those have improved markedly. So from that time 20 years ago, the prognosis for somebody needing advanced therapies have remarkably improved with ventricular assist devices and transplantation. So there's a much smaller proportion of patients when they present early enough that we can get therapy on that will advance, but when they do advance, we have even better therapies now that we can offer to improve outcome.
When I was first diagnosed, I clearly remember being told that had I not lived in a city like Los Angeles, I would have died. What are the statistics nowadays and the changing, evolving medicine, especially for people that are living in rural communities or globally?
Yeah, so it really is important to educate yourself. There's a lot of information from organizations like the Heart Failure Society of America, the American Heart Association, about what are evidence-based treatments. And, really making sure you're in the right clinical setting for you or seeking out second or even third opinions as necessary. With telehealth, there's opportunities to get access to experts, even if you're in remote locations. So getting the proper care setting really matters. At UCLA, we invest heavily to ensure no matter which of the clinical sites that, patients are being treated with the best therapies, and we're monitoring that and constantly doing quality improvement efforts to make sure that each patient each time is receiving the right therapies and being closely and appropriately monitored.
With the support group, there's also patients that come in that have been put on Amiodarone, which is a medication that I know I was on prior to having an ablation. Can you tell me more about those antiarrhythmia medications?
Yeah, so there are a number of different antiarrhythmic medications. Some of them can actually, in patients with cardiomyopathy or heart failure, actually make arrhythmias worse. So there are a number of drugs that we actually try and avoid. Amiodarone is one that has been shown to be safe in individuals with cardiomyopathy, but there can be some side effects of the medication, and with long-term exposure can be damage to the lungs or the liver. And so we often, if we use the medication, we'll try and use it for relatively short term. There are some individuals where there are no other options for their arrhythmias, so longer term use of the medication or updated versions of the medication can be used. We also have gotten better at these ablation therapies, and we also have implanted defibrillator devices for those with more serious arrhythmias where we can implant those. They're constantly monitoring the heart, and if necessary can either pace the heart out of the arrhythmia or actually render a shock, a defibrillation of the heart. And they're actually fairly successful and have advanced features and functions. So there are a number of things that we can do to treat arrhythmias beyond antiarrhythmic medications.
Can you explain to me what it entails to get cardioverted?
Sure. And so most common use for cardioversion is when someone is in atrial fibrillation and they have not come out of it to restore what we call normal sinus rhythm. But we can use a brief electrical shock to the heart to restore that sinus rhythm. And that is done through pads placed on the chest and a device called a defibrillator or cardioverter applying it. That shock to the chest can be a little painful, and thus sedation is used to make it so the patient doesn't remember that or experience that pain. So it can be an entirely outpatient procedure. Individual comes in, gets hooked up to the monitors, is sedated briefly, has the cardioversion performed, and wakes up and is hopefully back in sinus rhythm, and that is maintained.
What is an ablation?
So ablation really is where catheters are placed in the heart through different veins or arteries, so peripheral, in a procedure room. And then therapy is applied to the heart that disrupts the electrical pathways. Sometimes that's radio frequency energy. Sometimes it cools the heart or causes little cells to be essentially non-functional. So it's using catheters to disrupt the electrical pathway. This most commonly is done in the atrium, the top part of the heart, to treat atrial fibrillation. But in some cases where there's like a ventricular focus, or if somebody's having arrhythmias in their ventricle, you can actually do the ablation in the left or right ventricle, and that's called ventricular ablation therapy. And certain times it's in a focus for an arrhythmia, and that's the procedure that you had.
Thanks for watching Heartquake Media. Make sure you check out our website and social media for more information on heart healthy living. And remember, wellness starts with the heart.